Welcome to Clean Med KE, your home for clinical medicine and surgery made clear. Today, we are diving into a high-yield clinical guide on diuretics. Before we begin, a brief medical disclaimer. This content is for educational purposes for healthcare professionals and students and does not constitute medical advice. To understand diuretics, you must master the golden rule. Where sodium goes, water follows. Diuretics work by preventing sodium reabsorption in the nephron. By trapping sodium in the renal tubule, the filtrate, we create an osmotic gradient that keeps water trapped right along with it. This increases urine output, effectively reducing total blood volume and systemic pressure. To master these drugs, you have to know the map. There are 5 key pins, or sites of action, along the nephron. Pin 1 is the proximal convoluted tubule, where we find carbonic anhydrase inhibitors. Pin 2 is the descending loop, the site for osmotic diuretics. Pin 3 is the thick ascending limb, the home of the powerful loop diuretics. Pin 4 is the early distal convoluted tubule, where thiazides work. Pin 5 represents the late distal tubule and collecting duct, the site for potassium-sparing diuretics. Our first class is the osmotic diuretics, like mannitol and urea. Think of these as water magnets. These are large, pharmacologically inert molecules that are filtered but not reabsorbed. They stay in the tubule, creating high osmolarity that pulls water directly via osmosis, a process called aquaresis. Clinically, we use mannitol for the acute reduction of intracranial pressure, ICP, in cerebral edema, and intraocular pressure, IOP, in acute glaucoma. However, be careful. They are contraindicated in severe renal failure because trapped intravascular volume can lead to massive pulmonary edema. Next, we have Carbonic Anhydrase Inhibitors, CAIs, specifically Acetazolamide. These work in the PCT by blocking the carbonic anhydrase enzyme, which prevents bicarbonate reabsorption. This leads to mild sodium and water loss, but it's most famous for its use in altitude sickness, glaucoma, and idiopathic intracranial hypertension. The key side effect to watch for on exams is normal anion gap metabolic acidosis, NAGMA, due to the loss of bicarbonate in the urine. Now for the heavy hitters, the loop diuretics. These include furosemide, bumetanide, and torsemide. They block the sodium-potassium 2-chloride cotransporter in the thick ascending limb. By turning down this volume dial, they block 25% of sodium reabsorption, leading to massive loss of sodium, chloride, and water. These are your go-to drugs for severe fluid overload states like acute pulmonary edema, congestive heart failure, and liver cirrhosis. Thiazides, like HCTZ and chlorthalidone, are our primary BP controllers. They block the sodium chloride transporter in the early distal convoluted tubule. While they provide moderate diuresis, they also induce systemic arterial vasodilation, making them first-line therapy for essential hypertension. A unique high-yield benefit, they enhance calcium reabsorption into the blood, which helps prevent recurrent calcium kidney stones and aids in osteoporosis. Finally, Class 5, potassium-sparing diuretics. Their core mechanism is preventing sodium reabsorption while halting the excretion of potassium, K+, and hydrogen, H+. We have 2 types: aldosterone antagonists like spironolactone, which block steroid hormone receptors, and ENaC blockers like amiloride, which block sodium channels directly. Spironolactone is particularly powerful because it reduces mortality and cardiac remodeling in CHF and is the treatment of choice for Conn syndrome. Let's look at the electrolyte battleground. Loops and thiazides both lose sodium and potassium, leading to alkalosis. However, loops lose calcium, hypocalcemia, while thiazides save calcium, hypercalcemia. K-sparing diuretics are the only ones that cause hyperkalemia and acidosis. Also, remember that loops and thiazides can increase uric acid levels, potentially triggering gout. In cases of massive fluid overload, such as severe CHF, we use sequential nephron blockade. Step 1, use a loop to remove bulk volume. Step 2, add a thiazide to prevent the distal tubule from compensating. Step 3, add a CAI to combat any metabolic alkalosis. Step 4, add a K-sparing diuretic to protect potassium levels and boost the final diuresis. To simplify your clinical decision-making, pulmonary edema/CHF, use a loop. Essential hypertension, start with a thiazide. Cirrhosis with ascites, reach for spironolactone. Altitude sickness, use a CAI. Elevated ICP, use an osmotic like Mannitol. Always keep a watch list for adverse effects. Ototoxicity is a risk with loops, especially with rapid IV push. Sulfa allergies are a concern for loops, thiazides, and CAIs. Gynecomastia is a classic side effect of spironolactone. And watch for gout exacerbations with both loops and thiazides due to competition for uric acid secretion. To recap our high-yield points, loops have the highest efficacy, but lose potassium and calcium. Thiazides have moderate efficacy and are unique because they save calcium. K-sparing drugs are the weakest diuretics, but are vital because they save potassium. Finally, CAIs are unique for causing acidosis by losing bicarbonate. Thank you for learning with CleanMed KE. We hope this structured guide to diuretics helps you in your clinical practice and exams. If you found this high-yield guide helpful, please like, share, and subscribe for more clear, structured clinical content. See you in the next one.